We are kindly requesting everybody to take their seats so that we can start with the next session. Thank you very much. Before I pass on the floor to Mr. Mwenda, our moderator for the next session, I would like to make a few announcements. The first one is that you're all encouraged to download and use the Africa Health Forum application from iTunes or the Google Store. This app will enable you to access the program, the schedules, the documents, and social media. Feel free to share the proceedings as widely as possible. On Twitter, on the hashtag WHOAHF and hashtag Putting People First as highlighted on the screens above. Or you can share on any of your social media profiles as you wish. Please note that the forum is also live on YouTube, and we encourage you to share this as well. In terms of the venue, please note that all the sessions will be held in this room, with one exception. The exception is the side event on e-health, which will be held in room AD10. I repeat, AD10, which is on the ground floor. Please also be informed that there is a clinic on the ground floor for anybody who might need to use this service. The ushers can direct you. And finally, for those who may need interpretation services, please pick up the headsets from the back of the room. Let me pass on the floor to Mr. Mwenda to begin deliberations on the first session. Mr. Mwenda, over to you. Thank you.
Thank you very much, Madam. We have run out of time. I don't know how much time we have now. It is 20 minutes to midday. We were supposed to begin 10 minutes ago. I would like, therefore, to be very quick and introduce our panel. Right on my left-hand side is Mr. Tim Evans. He's the Senior Director of Health, Nutrition and Population at the World Bank Group. I think that is sufficient to know his credentials. Next to him is Ambassador Claver Gatete, who is the Minister of Finance of Rwanda. Last year he was voted the best Minister of Finance in the African continent. And next to Ambassador Gatete is Honorable Sir Achengo Pendi. She's the Minister of State for Health in Uganda. And after her, we have Dr. Gitahi Githinji, who is the CEO of AMREF Africa. After that, we have Carl Manlan, who is the Chief Operating Officer of the EcoBank Foundation. And finally, we have Fletcher Tembo, currently Director for Making All Voices Count. Gentlemen and lady, welcome to this panel. And without much ado over nothing, I would like to invite Tim to give his main presentation. I hope it lasts 10 minutes.
Great. Well, thank you very much, Andrew. And let me begin by thanking WHO for the invitation to speak today, and also acknowledging the presence of the honorable ministers, a tremendous number of distinguished colleagues, and old and new friends. And so with that, all protocol observed. At the World Bank, they sometimes say 10 minutes is a very long time. And so I will do my best to try and get you through this. I've prepared some pictures to go along because that's sometimes more interesting to look at than to listen to what I have to say. So a few remarks related to universal health coverage, and then I'm going to provide some indications of places where I think financing is so critical, but not with any suggestion that there's a simple solution being advocated by the World Bank, rather to engage you in thinking ahead in terms of the brave new world of finance. And my talk is fast-tracking a healthier, wealthier, and more secure future, because I believe that's really what's in front of us if we can figure out the financing challenge. So, first slide, please. First slide, please. Excellent. So here we have my president, Jim Kim of the World Bank, and the Director General until the end of this week, Margaret Chan, who are at the World Bank 3 years ago talking about taking on universal health coverage. We heard this morning from the Prime Minister of Rwanda that the new Director General, Tedros, is following on and making universal health coverage his clarion and first priority at the World Health Organization. I begin with this because we have to advocate, and we have to advocate strongly, that this is not just a health issue, it is also a development issue. And that's why our president has taken on UHC. UHC is absolutely central to the achievement of our development goals, our SDGs. Next slide, please. It is the right investment, in part because health is a right, and anything that improves health is an opportunity that all citizens must enjoy. So we have longer, healthier lives. We have better nutrition. Nutrition has been relatively neglected. Very high rates of stunting are compromising the educational and employment opportunities of future generations. UHC can help meet the demands for family planning, and on a continent like this where we're still pre-transition in terms of persistently high fertility rates, there's a big demographic dividend that can be achieved with UHC. But UHC can also, appropriately implemented, halt epidemics, and we know those epidemics can derail economies. And very importantly, the health sector is a growing source of decent jobs, and we know that it employs more people disproportionately relative to other sectors over time. And finally, there is much less impoverishment when you get UHC right. And we can go further. With respect to SDG 1, the goal to eliminate extreme poverty, we will never be poverty-free without UHC. Next slide, please. Last year in Nairobi at the TCAD meeting, the World Bank together with WHO and other partners released a UHC framework in Africa. And this framework was really recognizing, first and foremost, that there is a very strong political commitment to UHC already, that there's an expectation in the population, as measured through the Afrobarometer, that everybody should have access to good health care that they need without the risk of financial embarrassment. And finally, there are a whole set of opportunities to accelerate progress, which relates to understanding the diversity within the continent, but also the common challenges, and cultivating and bringing together some of the homegrown innovations and solutions that could be spread and shared. So this framework, next slide, really identified 5 entry points that we felt were generic, and I won't deal with all of these. It's just to say that when we talk about financing, it's not to suggest it's the only area of focus. These other areas related to targeting the poor and marginalized, people-centered services, strengthening health security, and political and institutional foundations are also extremely important. Next slide. Now, we are now 2 years into the SDGs, and we know under Goal 3 there are a set of time-bound ambitious targets. This is just one of them, the goal to achieve child mortality rates of 20 per 1,000. And the yellow on this graph is the excess mortality, child mortality across African countries. And the basic message here, you can see some countries have further to go than others, but we have less than 5,000 days to 2030. And if, in fact, we're going to achieve the expectation of 20 child deaths per 1,000, we have a lot of work to do. There's really no time to waste. Next slide. The framework paper that I showed earlier talked about substantial progress already in Africa. And so in many respects, we have to recognize that we're building on strength. And on the left side, you can see some of the issues related to important progress that is visible across the continent. Good service quality coverage or improving, non-state health providers that are playing active roles, and essential public health functions beginning to get more attention. There are, however, as in every set of health systems, a set of challenges that have to become the focus of policy. Next slide. When we look a little bit more in depth at financing, we've seen over time throughout the MDG period that in fact health spending per capita increased on the continent. When we decompose that, we find that the primary driver of that increase in financing was development assistance, not domestic resources. And when we looked and compared 2000 with 2014 in terms of the number of countries that had met the Abuja target of spending 15% of government money on health sector, there were 4 countries that had achieved that level in 2000, and there were 4 countries that achieved that level in 2015. And those 4 countries in 2015 were different countries than the 4 countries that had achieved that level of financing in 2000. And so and UHC puts a very strong priority on government-led financing, you can see that the Abuja target didn't take us systematically in that direction, and there's a lot of work that needs to be done. The consequence of this is on the right side of the graph, which is when you have insufficient financing, when financing of systems is in large part or majority pay-as-you-go, then people are impoverished in accessing care. And our estimates as of last year were there are about 11 million people that fell into poverty due to health payments every year. Next slide. If we look at the nature of that expenditure, catastrophic health expenditures, they increased over the MDG period from about 1.2% to 5%. So there was actually less financial protection in 2014 than 1995. And very importantly, with a pay-as-you-go system, the poorest often, approximately 1/3 of those in need of care, do not seek care because they're concerned about the financial implications. Next slide, please. So, if we move from Abuja to Addis, Abuja was the declaration that African governments would put 15% of government money into health. To Addis Ababa, where we had the UN Conference on Financing for Development, the discourse on financing has changed. There's first a very strong focus on domestic resource mobilization from both the public and private sectors, with transparency and accountability, and development assistance has a role as a contributor and a catalyst to strengthening national systems, and a very important role related to facilitating transition in financing as countries move from low income to middle income. So, next slide. In the context of Addis, the World Bank, together with partners, launched something called the Global Financing Facility in support of every woman and every child. And this was really, next slide please, to identify 3 functions that we want to achieve through financing. The first function is smart financing. And by smart financing, we mean good value for money. And this, if you're going to approach any Minister of Finance, is really the first consideration. If you don't spend all of your resources if you can't account for those resources, if you're spending them in ways that don't serve the entire population, if it's clearly inefficient, both in allocation and in execution, then it's hard to go the next step with the Minister of Finance and ask for more money. So we need to really focus on getting more health for the money, which includes best buys and best types of delivery systems. If one can show that the system is using existing monies well, then the second part of this, previous slide please, is scaled financing. And this is the recognition that if you need $50 per capita for financing, you can't finance your system on $25 per capita. And so you have to have some strategy which is inclusive of the public and private sectors to get from 25 to 50. That needs to be part of a medium-term expenditure framework and financial planning. And finally, on sustainability, it's very critical that one begins to think about how development assistance is additional and contributing to strengthening of national financing institutions and not substituting. Next slide. So a couple of examples now. This is a picture that could be anywhere, and it's what I call the epidemic of medical equipment waste. These are wonderful machines that have come from who knows where, but have not found their way into use. And they may never have been used. And when you look at the factors that are responsible for this situation, high acquisition costs, problems in installation, maintenance, and problems in spare parts, you have a massive source of waste and recurrent cost in all systems. Next slide. However, Kenya's managed equipment scheme has actually changed that, because now it procures across the 47 counties 5 different lots of equipment, and the time to delivery has gone down by over 75%. You have equitable distribution of that equipment. Populations are now coming back to those facilities, and there's renewed trust in those healthcare facilities that prior were not providing the services the population expected. Next slide. It gets even more nitty-gritty, and I put this slide up not to take you through it, but these are examples from across the continent of how the cold chain has been improved in multiple settings. And the figures in black are the percentage improvements. And so these are nitty-gritty types of interventions, though that simple and small as they may seem, have a disproportionate impact on efficiency. And we really need to share and scale these efforts. Next slide. Decentralization is something that virtually every health system faces. And in Pakistan, there was a constitutional amendment in 2011 which basically abolished the Federal Ministry of Health. That created a lot of consternation and concern. However, one way in which this decentralization has been dealt with is the creation of a national immunization strengthening program. And working through the Minister of Finance, a national procurement scheme was identified that achieved a scale efficiency in the procurement of the vaccines, i.e. the lowest price for a market of 6 million children born every year. The payment for that national procurement was managed through the decentralized mechanisms of the government, which had very strong binding commitments for provinces to pay and to pay on time. So great example of how decentralization doesn't have to be an unfunded mandate. Next slide, please. We have big problems with respect to provision of financing when we think about the informal sector. They don't get a paycheck, and they often aren't part of the formal tax collection system. And when we look across low-income and middle-income countries, the informal sector is in fact the majority of the population. So please press on this slide. This is just a snapshot of Kenya. You need to press return, 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 return. Thanks. 80% of the population in the informal sector, 83% uninsured. Next slide. And you can see those are some of the characteristics of the challenge of financing in Kenya.
I really need you to conclude, because now it's, you've been speaking for 17 minutes instead of 10.
Yeah, I'll be finishing very shortly.
Please.
Yes. Okay, so what to do about that? And I think there's actually a very interesting innovation. Next slide, please. Which is called M-TIBA. And this is building on a mobile banking platform, which is very well known, not only in Kenya but around the world. It's just called M-PESA. But here there's been a creation of essentially a medical savings account that can be contributed from anywhere and that can only be used in accredited health facilities. And I think the reason I'm presenting this is that this may be a way, a new way of thinking about how we move into the future and cover the financing of the informal sector. Next slide. There are a whole set of challenges related to preparedness, and this cover of time suggests we are not ready for the next pandemic. Next slide. This was Zero Case Village in Guinea, where Emile in Melianudu was the first victim of Ebola in December 2013. We know the story of Ebola. Next slide. And here President Sirleaf Johnson was part of the public health measures taken to make sure that that epidemic didn't spread. Next slide. The important part of preparedness is that it is dependent on frontline workers. And so I think one of the things that we've come to realize is that there is no UHC without primary health care. But we have to be smarter about how we finance primary health care and also preparedness. Next slide. In that context, we've just issued a report on how to finance preparedness at the national level. This looks at the different sectors involved, health, agriculture, and disaster management, and also pays attention to the very important issue of surge financing. It's not only financing during peacetime, it's how you mobilize resources in the context of a crisis. Next slide. Yesterday, in Geneva with the new Director General, Tedros, we had the first meeting of the Pandemic Emergency Financing Facility, which is a global mechanism, but which covers all IDA countries. And this is a source of surge financing in the context of a crisis should we have another outbreak. Next slide. And next slide. So, I want to finish by saying part of our financing challenge is to anticipate now what lies ahead. These are changes in smoking prevalence across the continent. And you can see the arrows indicate massive increase in financing in tobacco. What that implies is there needs to be a commensurate change in the increase in tobacco taxation, what we call sin taxes, a very valuable complement to the financing. Second to last slide is anticipating not only what lies ahead, but what flies overhead. And this is a picture of our President, Jim Kim, standing in front of the drone station here in Rwanda. And the drones here are supplying the blood to every outlying clinic in the country and have been doing so for the last year. This is saving patients who have needs for immediate blood transfusion, particularly women who have postpartum hemorrhage. The point here is how does one begin to anticipate this technology and get it into a sustainable financing system for the system as a whole. Last slide, and I finish with this. The only way we're going to make it to UHC is if we have the workforce that will lead us there. People, 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 people first, but you have to have the professionals, the scope, the numbers, the qualities in place. How we finance is something that we could do a lot better on. If they consume 90% of the ministry's budget, then we don't have much room for financing other things. How do we...
Availability of a large volume of public resources, which is state revenues, to finance universal health care.
Stakeholders together to see how do you finance it so that you don't do things in a very disjointed manner. So by having that, which you have done in Rwanda, then you say, well, how do we manage the money? And the management of the money is the most important for us, because the most efficient way of managing this money will yield quite incredible results, and making sure that the whole system works as one system. We are now innovating, of course, new ways of financing apart from the budget and our development partners, because we know that the resources from development partners is declining continuously, and we are just innovating. Not going to say what we are doing now until it comes out, but let me just give you a hint. One of the areas is a health bond, or the social impact bond that we are raising. Normally, every quarter we go to the market to raise money. But by identifying the people who are more social, health-oriented, we want to issue a bond whereby the money that comes from the bond is financed through the budget, not for the health sector, but the interest that we'll be paying goes straight to the health sector. That way, this will be an additional money over and above the budget that we are providing. We're also trying to see the community-based bonds that we are establishing at the local government level, to see how we can have a system, we can have a method of how we can generate extra resources that can continuously supplement or be able to replace the donor resources that we are anticipating. So we are now innovating, but at the same time, we have rolled out the financial management system that's quite unique, that we believe that the money that is put in the health system can be used properly. In addition to what government provides, we want to make sure that the hospitals can also make money, meaning we have professional doctors, we have equipment. How do you make money using the equipment that we have invested in properly? And how do you make the equipment become an attraction to the actual doctors, not necessarily from the country, but also from outside? This way, then, we can have it as an import commodity, and at the same time, it can prevent the Rwandans going outside for treatment. Thank you.
Thank you very much, Honorable Gatete, for keeping time on the dot. I want to come to Uganda's Minister of State for Health, Dr. Sarah Achengo Pendi. You have been in the Ministry of Health. What is your own experience of Uganda and value for money?
Thank you very much, moderator. I want to first of all state that health is a human right, and the government of Uganda does recognize that, and that is why it's the responsibility of government to actually provide healthcare services to its population. And this is enshrined in the Constitution of Uganda. Of course, over the years, we've had challenges before, but over the years, the government has been addressing these challenges. And as you all know, we all have been heavily depending on external financing for our healthcare programs. And of course, Uganda has not been an exception to that. You all know, ladies and gentlemen, that Uganda, just like most of your other countries, are facing this double disease burden. We have the communicable and non-communicable diseases. And while our focus has really been on the non-communicable diseases, on the communicable diseases, majorly malaria, TB, and HIV/AIDS, we are seeing a rise in the non-communicable diseases. And of course, following the Almata Declaration of 1978, Uganda did adopt that approach of the primary health care. And of course, we do provide services free of charge in most of our facilities at the primary health care level. However, while these services are free, we realize that tertiary care cannot be free. And of course, a fee is charged. And of course, we have to move away from external financing to support these interventions and find our own resources to deal with our challenges in country. You are aware that, borrowing a leaf from Zimbabwe, we are now putting in place an HIV trust fund to deal with funding for the HIV. We're also going to have an immunization fund, because that is really preventive, and most of our support to immunization has been through from Gavi. So these are some of the interventions that we're putting in place, but of course not forgetting the fact that we have to have our own health insurance scheme in place. And right now, as we speak, we are finalizing the bill, and very soon we hope that this will go through Parliament and we have this National Health Insurance Scheme in place to support the health interventions in the country. But of course, am I 2 minutes over?
You still have 1 minute.
Thank you. And of course, all these are in place, but we should not forget the power of innovation. We have, as a country, also been promoting local innovations in dealing with our health challenges. And as we speak now, we have various innovations. For example, we have a team of engineers, ladies, who came up with, under the Afrigal brand name, MDEX, a tool that can actually help detect the sickle cell. We are grappling with this challenge of the sickle cell disease. It's fast rising. It's now a very big challenge in our country. And of course, not only that, we have other challenges around, and of course, other innovations going on around the other challenges. Another tool that has been developed is that to detect the TB. So I just want to indicate that as government of Uganda, definitely we are moving towards universal health coverage, but we cannot do that without reforms, looking at accessibility, which we have dealt with, looking at affordability, but also most importantly, the quality of care. And this is important. And we have also been dealing with the human resources for health to ensure that as we talk about provision of health care, it should not only be the infrastructure, but look at the human resources who are supposed to be providing these services. Thank you.
Thank you very much, Honorable Sarah Opendi. Let me come to Dr. Gisinji. You have been working from the side of civil society. There is an obsession on the African continent, I think also in the world, that if there is to be healthcare provision, it must be provided by the state. And of course, as I said, states in Africa are poorly developed in terms of both human and financial capacity and institutional capacity. But do you know of any innovative ways through which healthcare can be delivered by complementing or even supplanting the state in Africa through community initiatives that are non-state based?
Thank you, Andrew. I want to first pick up from a comment that has been made by the Honorable Minister, which is about health as a human right. I'm yet to see a family in any of the African countries that has lost a child and has gone to court to sue the government for not delivering health care to that child. The day that happens is when the issue of health financing will be resolved, because governments will wake up and see that actually the citizens are actually understanding that health is a right, and therefore a right is to be demanded if it's not delivered. Right now, as we discuss, our communities sit and wait for us to provide the health care. I think when we see families going to court, this issue will be resolved. That said, let me try and get back to your question on health financing. I think for me, to borrow from Animal Farm, all the WHO building blocks are equal, but health financing is more equal than all the others. Because when you achieve health financing, you achieve all the other in terms of service delivery, all the things you're talking about, service delivery, human resources for health. So when you talk about innovative solutions that we have seen, my view is actually that we have we are doing an exam that we have the answers. We may not even need to look at new initiatives. If you look at where governments have tried to provide healthcare wholly, like Cuba and others, they have really not succeeded. So I'm yet to see a successful, fully public finance healthcare system. I'm yet to see a donor who has assured domestic health or health finance for longer term in a sustainable and an unchangeable way. We know now what's going on in the West. The donor funding is going to reduce. So all these are challenges that we are going to find. But the innovative solutions that we have seen working involve the communities. They involve the communities. Rwanda is a good case. Rwanda, through the community-based health insurance, mobilizes close to 70% of the funds of that community-based health insurance from communities. And I think the challenge we have is that we see the answers, but we have refused to really bring them on the table. We expect our communities to insure their motorcycles mandatorily. You cannot run a border or a motorcycle in any of these countries without having insurance for it. But you're okay to go around without insuring your life. That, for me, is where the problem is. That we must, the most successful way I've seen is to make health insurance mandatory and then provide subsidies for the poor and then pull resources from the communities because the communities have the resources. Now, how do we do that? We do that by following models that have been followed around. We have seen Rwanda. We are seeing now some tests going on in different countries as well. Kenya, the National Health Insurance Fund, Ghana, the National Health Insurance Fund. We have to think about pooling resources from communities, and then after that you can start to think about utilizing them and improving the provision of the services that they find in the public sector. So this is really what I would say. But at the end of the day, we have to utilize the power that exists in the communities to demand that right, and when they demand that right, then the governments will have to look for the solutions that are tenable to provide that care in a
Thank you very much, Dr. Githinji, for keeping time. I want to come to Manlan. You are working with the EcoBack Foundation. You told me you have 3 major ideas you think that can change Africa's health spending and make it much more efficient. Please share them with us.
Thank you, Andrew. Good morning, everybody, and honorable ministers and guests. I think we have every year there are 10 million Africans that join the labor market. And why this is important, we have 350 million that belong to the middle class. And if we were to ask each of them to contribute $1 per month, within a year, we'll have 4.2 billion. It might sound impossible, but everybody has a cell phone. So collecting the money using digital financial services is not an issue. The second part is around where do we want to put our resources? We know that a lot of our communities provide food for the nation through agriculture. When we speak about the last mile, we may want to reverse and think of them as a first mile, because if they're not healthy, if they don't provide for agriculture, we may have a different problem, which has been alluded in terms of nutrition. The third point is around data. And the heads of states have agreed to have the Africa CDC. The Africa CDC needs to be funded, because with better data for NCDs, but also better data for communicable disease, we will be in a better position to better use the resources that we have and target the investment.
Okay, that is you have used exactly 2 minutes, or less than 2 minutes. Let me come to Tembo. Making all voices count, assuming we gave every poor African a voice, and following what Githinji was saying, all of them go and take their governments to court for failing to deliver health care, and given that these countries are too poor to afford it, don't you think we would have no government and would have anarchy?
Well, thank
Isn't
you very
Dr.
much.
Githinji actually suggesting a solution for advocating for anarchy?
Thanks, Andrew, for that question. Maybe let me come to it. First of all, by putting a preamble to it, that I like what Tim said about the move from Abuja when he showed statistics there, and he said only 4 countries managed to achieve the 15% budget. And then he talked about Addis, and then there is emphasis on domestic revenue and also transparency and accountability. But what one needs to question is, what can we learn from these disparities and these disasters? And the Sustainable Development Goals have advanced in that area by talking about looking at inclusive societies, and transparency and accountability belongs to that. Now, our engagement with citizens as making all voices count is about finding those innovative solutions, not us against them. They are collective action solutions. It is about our health, our health, our say. That's what they normally tell us. We have a voice, and I like the earlier remarks that this is not looking at citizens as beneficiaries, but as contributors to policy. If they are contributors, therefore they have also to monitor what is actually happening. And that's what it is coming about. It's not about us and, drawing down governments. And, the strong institutions issue in goal number 16, many governments interpret it by putting oversight institutions with boards appointed by themselves. But what we need is institutions where citizens have a say and have a construction which enables progress to happen. I've seen only one, as just last week I was in Ghana on extractives oil and gas, which many African countries now are into. They have set up a public interest accountability committee. That's the only one which has ordinary citizens around, and they produce data using the law to demand what exactly has government made from revenues. So yes, we are talking about financing. It's not just about more money. It's making money available where it should be available. Because citizens, ordinary citizens, find their clinics empty. They don't have anything there. So now there's a lot of technological innovations, and making of voices count. We work on that area a lot, about how you use technology in order to enable citizens to engage more effectively with their representatives, with government. And most of the frontline nurses and teachers and what now are beginning to like it, because many times they have been blamed for not putting medicines in the clinics, when in fact it's the system itself. And when we are talking about system, we're not talking about the hardwired system. We're talking about decisions, the way decisions are made. Many times we know in Africa there are IFMIS now, the integrated finance management systems, but under it is a lot of decision making that still beats that system. So we need to look at the soft interactions and trust and what that make what that system is, and how our citizens' voices are counted in that system. So those are some of the things that we work in 8 countries in Africa, 4 in Asia, and there's a lot of lessons just that I don't have time, but I could have shared. But thank you for the moment.
But Tembo, could you answer for me a question? Why do you think that the public pressure or public opinion can shape more innovative ways of efficient healthcare delivery? Because public pressure may actually lead to dysfunctional delivery of public services.
Yeah.
I am very suspicious, by the way, of the popular will.
I like that question, but I said this pressure is informed pressure. It's not just going to the roads just because you don't like something. We work a lot about evidence, so they will go there with statistics. They know we received this much medicine, but we're not accessing it. This government put this much in the budget. So we are putting evidence at the front. So it's a pressure with evidence, not pressure just to break the system.
Okay. Manulan, Tim talked about smart financing to get value for money. What would smart financing, in your view, include? How do you find innovative ways for smart financing of health?
So we have one example in Rwanda, which is based on what the government already put in place, which is the National Health Insurance Scheme. So we are working with One Family Health, another institution, including GSK, where EcoBank Foundation provides a loan subsidy for nurses, majority of them women, to actually have access to capital to run their own businesses. The first nurses that started the program are now at the end of the period where they're paying off the loan. It means that they are creating jobs for themselves, but they're also creating opportunities for others. And regulation and legislation is very important to provide a framework for the private sector to be able to involve. If we use, there's an example that was mentioned about Zimbabwe, where they use the AIDS levy, using 3% from income tax and 3% from profits from companies. They have raised, I think, more than $50 million. It is possible to raise money from Africa. It is possible to raise money from Africans when the legislation, using data, allows us to have a different conversation.
Okay, but let me Dr. Kisinja, I come to you, Honorable Sarah Opendi. Isn't it embarrassing? Because Tim in his presentation said that the biggest source of increase in health funding in Africa is from donors. Isn't it embarrassing that our governments have to look towards international charity to increase funding for the health of their own citizens? And how are you trying to resolve that in Uganda? We seem to always have a lot of money in Africa available for corruption and for so many other things, but why not for health?
We do have funding for health in our African countries. But like I said before, it's not adequate to meet the needs, to meet the demands of the population. We as government of Uganda, you are aware that close to 90% of our funding initially was from development partners. This has drastically reduced to about 65% now. And we are moving further. We hope that in the next 5 years, this will drop further to maybe less than 50%. And of course, while you say it's embarrassing, you know that the world is now a global village. we must all put our heads together, those with resources, support those that do not have. Because I'll move with my disease from Uganda and move to Europe or USA, and of course the population there will get this disease. So it's not really embarrassing, but it's a situation that we are gradually moving from, and this is why we are all committed, the SDGs, specifically 3, and we are all committed to this universal health coverage. But most importantly, in my country, you are aware that we are now focusing more on health extension workers who will be supervising the voluntary teams at the village level to focus mainly on prevention of diseases and, of course, acting as a link between the community and the health facilities.
Brilliant. I actually think we ignore so much prevention, and yet that is where the biggest return on investment would be. So if Uganda is focusing on that, I'm really impressed. But Dr. Githinji, before I come to Clava and Stephen, don't you think this obsession with the government involvement in health is the wrong thing? Well, government can be involved at financing, but we have a view that if government has to finance health, it must also provide it. Can't government finance health through private healthcare providers and achieve greater efficiencies that way?
The fascination with government is that government is the only system that can create policies and regulations for the health sector. That's what the government needs to do. The government of Rwanda many years ago came and said, we are going to have mandatory health insurance. That is the step for government. Then after that, you create systems for the people to work, number one. Number two is, even when we talk about Africa having a very low per capita expenditure on healthcare, $100, $109, whatever you call it, we are putting it, and I'm happy about what the Honorable Minister for Uganda was saying, we are putting it in the pool of disease and death. We are putting it at tertiary and secondary level. Only the government can come back and say, we are going to focus our resources into primary health care. Now, where the money comes from is where I'm saying that the government needs to put systems so that it's mandatory to have health insurance. We know that if I need to travel to Europe now, I cannot travel there without health insurance. Why is it that here we allow people to actually stay around without mandatory health insurance? We might identify the poor, subsidize them, and everybody else, whether you are formal or in informal sector, must show up with a card to the public hospital. The problem now is that the entire referral system has flopped, Andrew. We have people walking into referral centers for cough and cold without a proper referral system. We need to refocus the investment. In fact, I keep saying, and we're discussing with you about the book, The Greatest Care. In that book, it says, the more specialized a doctor is, the more useless they are to the public health system. And that's the reality. And I'm a doctor, and I can't say that again and again. The thing is, the governments in Africa need to refocus the investment down to the primary health care and then create a referral system for specialized care. Only the government can do that. And then the citizens can demand the right for health care.
Okay, Tim, I want to come to you. The World Bank, from the little that I read, seems to be obsessed also with health care, but from the clinical part of treatment. And my own reading is that most healthcare improvements come as a result of improved sanitation and nutrition and things like that, which come also from improved education and improved incomes. In which case, really, don't you think poor countries should much more focus on economic growth, which will improve incomes of people so they can get better nutrition, better education, and therefore better hygiene? Rather than this focus on increasing spending on health, they should increase spending on perhaps activities that create jobs and create economic opportunity. And that may be the best solution to healthcare that we are looking for.
Thanks. That's a great question. And this was one of the reasons why the World Bank didn't get into the health sector until the late 1970s, early 1980s. In fact, they did nothing in the social sector because they felt that the social sector up until the 1970s was inefficient and a risk to economic growth. As somebody who studied human capital, which is the stock of health and education in the population, when you examine what drives growth over time in economies, about 2/3 of growth in an economy is driven by human capital. So if you have that stock of health and that stock of education, then your economy is going to grow much faster than it will if you have ill health and illiteracy. So the bank, as an institution that takes a long time to learn the basics, finally figured this out in the 1980s. And in fact, our current president is so absolutely committed to this, he's created a human capital summit at the annual meetings next year, in which he's really making it clear to ministers of finance that if you want to not only grow your economy now, but have it grow in the future of the information world, of the fourth industrial revolution, you must invest in the health and education of your people. Otherwise, you'll miss the train.
So, the second challenge to you, Clever, before we come to the to the audience, is: does it require government to be the investor in health and education? If government invested in things that create opportunities, like jobs for the population, can they pay for their own education and their own health? In which case, some of the results that we get from the greatest things we can do is not to do things directly, but to do things indirectly that stimulate, that instigate, that spur the other consequences. In which case, a growing economy with more jobs will create a population that can fund their own education and their own health. Rather than have a nanny state, you have people taking care of themselves.
Thank you very much, Andrew. Of course, government alone is not enough. The private sector has to come in, has to be part of the system. But let me come to 3 points which I think are very, very important. One is what my colleague has just mentioned, the formula that you use in terms of providing the health services. And that one is mandatory insurance. In developed countries, as you know, they have, most people who work, of course, they have health insurance. They also have employment health insurance. And other people who are not working at all, who has no way of working, they are supported through the welfare system by the government providing that kind of insurance. Now, in most of the rich world, they have access to money in terms of getting income, but in our own countries, the system is different. We have the people who work, who actually deduct some money from their own income, and that becomes insurance. And there are others who never get income or they don't get regular income. We have to find a formula in Rwanda here to see how do we categorize them so that they can make their own, whatever small contribution they can make, but according to their income on an annual basis. And that way we came up with a formula of Mutuelle de Santé, which is very, very useful, which is working, making sure that everybody here is insured. So the compulsory health insurance is very important. But also we knew that you don't simply provide money in terms of the health services. We had to make sure that it is results-based financing. In other words, we give certain benchmarks for the hospitals to make sure they can meet for us to be able to provide money. Thirdly, we had to pick and choose what to subsidize. Medicine, you don't pay taxes. Equipment, you don't pay taxes. Almost everything going to the hospitals, you don't pay taxes. That is a big incentive. Then, secondly, we know that we have to help ordinary people. They are not as well informed as people in the developed world. So the community health workers became very, very important because the community health workers are the ones working with ordinary people in terms of prevention, in terms of directing them, in terms of how to take the medicine, and so forth. So that also became very, very important. What we're emphasizing now is the whole chain from the community, where you can do the prevention, how the treatment is done, and also how research and development can be facilitated for sustainability purposes, and then providing incentives for.
Now, I want to come to the audience. If you have a question, if you have a comment, a contribution to make, please, you are welcome, and you are given exactly 2 minutes. I will be a dictator enforcing just 2 minutes, so that we can be able to have a lively dialogue. Okay. Somebody from Zimbabwe. Please give Zimbabwe.
Deputy Minister of Health from Zimbabwe.
Okay.
Well, because of domestic financing, we actually have a...
Speak to the microphone, please.
We now have a telecommunication companies.
5% on mobile data and telephone calls, a levy of just 5%, and then that money is taken directly into health funding. Please, when you're speaking, be as close to your microphone as possible. You can still look at my gorgeous face, but still focus on the microphone so that you can be heard. Okay, any other question or comment? Yes, sir.
My name is Jean-Claude Mbanya from Cameroon. I just want to ask the panelists, and especially the ministers here, given the poverty-stricken African countries, especially in terms of healthcare, why is it that they cannot suppress some National Day feasting of champagne and everything so that they can use this money for healthcare finance?
Okay, what he's saying is what Magufuli has done in Tanzania, has cancelled some national celebrations and shifted money to health. So why can't we all follow in Magufuli's 5 men, actually 6 including me, but can we have a lady in the audience?
Please, I just want to say 200 million can buy insulin for all type 1 diabetes patients in Uganda for 5 years.
200 million shillings is about $60,000. Yes, I think, yes, there is a lady there I can see. Yes, madam.
Thank you, Chair. Thank you, panelists, for sharing some experiences around handling issues around financing and drop-off donors funding. I'm wondering how we can bring PPPs, public-private partnership, into research and development so that we can answer our own problems as Africa. As now, like 95% of the medical products and new technologies that we are using are mostly imported from Western countries. So I'm wondering how we can do kind of exchange where not considering those private partners as just private, but also considering them as partners and see how we can answer our own ground problems. Like Honorable Sarah discussed about how Uganda is trying to bring those new technologies, production of sickle cell disease devices. I'm wondering how we can put efforts on linking private institutions, bringing them together with the health system and try to answer our own problems. Through research and development, we can be able to answer those donors' decline of fundings and other issues around. Thank you.
Thank you. By our own institutions to finance those kind of research, there is so much that we can save in terms of resources that will be lost. And this is the only way that we can really sustain the financing, the health sector. Research for us is very important in Rwanda.
Okay, let me come to Tim. She also talked of public-private partnerships. How can the state work with the private sector to provide healthcare in an efficient manner that brings value for money? Because we know that the governments historically have always been incompetent and corrupt.
Yes.
So how, and it seems that when, in my language, there is a saying that if you get a goat that has foot and mouth disease and tie it with a goat that is healthy, the other one affects the other. So if you get the private sector to work with a corrupt and incompetent government, when the private sector gets corrupted by the government and then also becomes incompetent, should we keep these two people apart?
Yeah, I think when it comes to corruption and lack of transparency, the private sector and the public sector are equally culpable, in my experience. And so I don't think there's that a denomination of being private or public excludes you from the imperative of being transparent to whatever publics you're accountable to. The issue, though, is that first of all, that the private sector is present in the health sector in many spheres, whether you like it or not. And I think what all governments need to do is to think about their role with respect to stewardship, the rules of the game, regulation, such that that private sector energy is actually nurtured to achieve the goals of the system. So rather than have health insurance for the very rich, which is really taking away the pool of resources that are necessary for cross-subsidization, you should be looking at trying to get as many people into the pool as possible. And therefore, the mandatory nature of insurance, or looking at ways in which you make contributions less voluntary, and that's why I think the digital financing revolution is going to be absolutely transformative. Those are ways in which the private sector can play a role, where the public sector may be much slower. We don't have the benefit of the 20th century major reforms of the welfare state. We're looking at a much more pluralistic and fragmented system in the 21st century that needs the guidance and the advice from the public sector, but also the participation of the private sector.
Thank you very much. Yes, I have a lady right in front of me here. Okay, I'm going to come to you, sir.
My name is Mary Amoyonzu Nyamongo. My comment is regarding the establishing funds. We have an HIV fund, we have an immunization fund, we'll have a cancer fund.
Where is that? In which country?
We were told in Uganda they have an immunization fund and an HIV fund. The challenge is we are trying to integrate health interventions. When we start having silo funds, are we going back again to silo management of these diseases, yet we are all supposed to be working towards an integrated approach to healthcare? That's a question also for Zimbabwe that said they have a fund for a specific condition. Thank you.
Let me come to a health expert like Tembo. Could you comment on what she's saying? Did you follow her question? She's saying by creating a specialized fund for particular diseases, we are disintegrating the financing of health. Is that a good idea?
Yeah, just from the perspective that I'm seeing it, I'm saying that maybe linking to the research bit that we had talked about earlier. These funds, when they are disjointed and there's no harmonization, sometimes indeed create chaos. But there's something that would be useful in them if they are meant to dig deeper into understanding what is happening in that particular sector where you are creating the fund for, so that you have an exit strategy or some ways of generating resources for addressing the issues in that particular sector, but still harmonized under a particular framework. So in terms of understanding things better, yes, sectoral sometimes is better because you can illuminate bottlenecks, you can illuminate interactions where private sector can participate, where civil society can participate. So that's where the beauty is. But if it's left as an end by itself, then it can create problems. So that's the way I would see it.
Okay. Honorable Opendi.
Thank you very much. I just want to say that we're not moving backwards, we're actually moving forwards. Because, as you're aware, if you look at our expenditure on, for example, from the national medical stores that procures and distributes medicine, close to 31% of our expenditure through that national medical stores goes towards HIV/AIDS. And all this is from the donors. All this is from the partners. So if the partners pulled out tomorrow, what are we left with? Shall we be able to deal with this challenge? And we are looking forward to our goal of having 90% of those HIV positive put on treatment so that the viral load can be suppressed. And the 90-90-90 goal is just for the year 2020. So we are not moving backwards, but moving forward, finding other ways of financing our own, healthcare. And of course, I've talked about HIV/AIDS as one of our biggest challenges. And Uganda, I think, is the second on the continent with having the highest number of people living with HIV/AIDS. If they are not on treatment, then we can have a very big problem.
Okay.
And of course, I also wanted to state, my brother there, that statement should not go unchallenged. Instead of buying insulin for 5 years, when we commemorate the World Diabetes Day, it's really to teach the population about diabetes, how it can be prevented. And it's not just going to sit and eat and drink, no. There are a lot of activities done by the Ministry of Health in that particular district for a whole week, focusing really on prevention, as I said before.
Honorable Gatete, just briefly in 1 minute, you wanted to comment on something?
Yeah, just 1 minute to say that really, I want to advise that the funds, we have had many funds for infrastructure, for agriculture, for health. If we are just to go by funds, we will not even be able to have a budget, because these are not sustainable. There has to be a clear system under which the health system is financed. It should be transparent, it should be open, and people know where the sources of money are going, and then trying to check the whole system, how it works. But if we go by the funds being established here and there, you'll have a shock in the system when those funds dry up.
That's a very good point. Let me come to Mauritius before. Let me come to Mauritius. Yes. You have been trying to catch an old man's attention. I'm sorry, my sight.
It's okay, thank you. My question is addressed to Dr. Timothy Evans. I'm talking about per capita expenditure on health. I mean, is there such a reasonable or realistic threshold above which we are going to see a difference in our African context?
I didn't get the question right.
I'm talking about per capita expenditure on health.
Yes.
Is there a threshold above which is going to make a difference? A reasonable and realistic threshold.
Okay, Manlan, you are right next to him. Did you get the question properly? Could you please answer?
The representative from Mauritius is asking whether there's a threshold by which, once it is reached, the exponential growth of solving health problem is going to happen. That was the question.
That's it. Your per capita expenditure.
The per capita expenditure, yeah.
But the question, would any one of you want to answer it? Yes, Dr. Kisinji.
Yes, obviously we have statistics from WHO that say what threshold. You know, I think the regional director talked about $80 per capita. Right now we are talking about on average 109. I think that's where we are. But many countries, I think what this gross number does is that it buries a lot of iniquities, because some of this expenditure is not government. Actually, most of it is not government. It's actually out of pocket. So when you talk about even the 8109, in some countries, 70% of that is out of the pocket. So I think that's where the issue is. But there are already thresholds that have been defined. But now that I have the mic, Andrew, I wanted to comment on the private sector issue as well, and say that the real issue about private sector is involving them in primary healthcare. Because right now, when you involve private sector at tertiary and secondary, Tim gave examples of private sector involvement in Kenya with the managed equipment service. It's very easy, because private sector is looking at immediate return. We must never forget that. But how do you bring private sector to participate at primary healthcare? That can only be done if you unlock funds from the community, and therefore there is money to circulate in the pool, so that private sector has a return and an interest to come down to the primary healthcare. And that is where even community health workers become part of the supply chain and last mile delivery of services.
Okay, I have a gentleman somewhere in the middle there in a black suit, white shirt, black tie. Yes, right there. Yes, sir.
Thanks very much for recognizing me. I'm happy to be here and to see you again, my friend. I'm Dr. Charles Senesi. I'm a physician based for about 2 decades in Switzerland. And I'm head of the Afro-European Medical and Research Network, a network of professionals determined to give back to our continent of origin in whatever skills we can afford. And I'm quite impressed by the presentations we've had this morning about health financing. And we are also very concerned and inspired to help. We in the diaspora are also concerned about our continents of origin. And so we are determined to see how best we could complement your effort, which is why we congratulate the World Health Organization on organizing this first forum. And my colleagues there in the diaspora, we have all ears on you people. We are determined to help. You've spoken about finances. Good. It's one of the resources. We also think about the human resources. And we are determined to give the human resources to complement your effort. So be rest assured, we have all ears on you, and I'm especially here, very happy to be here. Of course, it suffices to mention the contribution of the diaspora to the continents of origin. We have experts here. But what I will dwell upon is that, given the human resources we are more determined to give back to our continent of Africa, so that at least this new way we have started will be sustainable, and we should give very good results. Thank you.
Thank you. Then I have Professor Maswa right here. You have been a healthcare professional for such a long time.
Thank you, moderator. And I'm from Uganda, but here as a member of the Independent Advisory Group to the Regional Director of WHO. And we congratulate Dr. Moeti and her team for bringing us here, and it's an exciting debate. So the point I'm rising to make is that health financing is about governance of society. And until the issues of health, education, which are key drivers of transformation, are taken on by our political leaders, our spiritual leaders, our traditional leaders, we are not going to make a difference. All these things we are saying, stop private sector, bring them in, and so on, are secondary. The most important advocacy I propose we make is one where the African Union heads of state, our ministers of health, will take health not as a consumptive sector as is being done today, but as a productive sector. And then the details of how we deliver health that leaves no one behind, the formulae are there. We haven't heard from the panel about the countries which have achieved good health at low cost. There are many countries like this in Asia, there are the Cubas and so on, from which the principles are there. And they all rotate around primary health care, integrated primary health care, participation of the people themselves, and then who pays, they will decide according to their history, their culture, but it is leadership above all. And leadership, of course, by political leaders, but by all of them, including us, all these Africans who are here, very well-educated people, very competent people. We go back to our countries and we are silent about the suffering of the people. So I really would like to, us ending here tomorrow, being committed, those of us who are here, to go back home and be leaders. Thank you.
Okay. So you can clearly see I selected the right person to be the last person to make a comment because he has a wealth of experience. Now, we have exactly 2 minutes to 1. This conference is this section is supposed to end at 1, and I want to end it at 1. I want to invite the organizers to come and give us their last talking points, so that at exactly 1, we behave like good students of European behavior and close this session. Thank you so much.
Thank you very much, Mr. Mwenda. Please, can we provide another hand of applause for all our panelists and all our speakers? It was a very interesting discussion. I have 2 main announcements to make. Lunches will be served in 3 different areas as follows. The Auditorium Club 1, on this level, just next to the auditorium, is reserved for the honorable ministers, the speakers, the moderators, the panelists, and the delegates. In other words, those with red, brown, and blue badges can utilize Auditorium Club 1. For the rest of the participants, there are 2 restaurants. The Filini restaurant on the right-hand side to the entrance of the convention center, as well as the Ladder restaurant on the ground floor of Radisson Blu Hotel, close to the pool. The second announcement is to remind you that there will be a side event on e-health in room AD10 from 1:30 to 2:30. All those who are interested are encouraged to quickly have their lunch and make their way to AD10. And we would like to encourage you to attend this very important discussion. Flyers for the side event will be distributed by ushers on your way out. And finally, session 2 on global health security will begin in this room at 2:30. Bon appetit.